Hello, I'd like to review bonding with you. So as a hygienist, you may wonder, why would I review bonding? Well, bonding is an essential part of orthodontic treatment, and once you understand the concepts of bonding, it'll help you also if you have any emergencies, and we'll get into emergencies in a few minutes. So what I want to show you in the process of doing a bonding demonstration, I want to show you the instruments that we're going to use today. One is an Explorer, which obviously you're very comfortable using. A hemostat, really it's called a Mathau plier, but most often it's referred to as a hemostat. This is a bracket holder. We already have a bracket in the bracket holder for your convenience. Of course, a Type-it-on tooth, a rectangular tie wire, which is a flexible wire, etch, sealant, and then the actual bond, or the bonding agent that's actually used to place the bracket on the tooth. And then this is one of the ties that's actually used to secure the wire to the bracket. So let's start first with the etch. Etching a tooth, what we want to do is we want to make sure, especially with this particular product, you want to cover the entire facial surface of the tooth. Ideally, the etch should be in place for 30 to 45 seconds, but really longer is not necessarily better, because if you leave it in too long, it really can compromise the quality of the etch. So I'm going to leave it in here for about 45 seconds. Okay, now that we place the etch, we also then rinse the tooth with a copious amount of water, and then we of course dried it. You don't have to desiccate it, but you will definitely make sure the enamel is completely dry. Then we're going to place a sealant. A sealant is a liquid, lightly filled resin that when you place it, you want to place it starting from the gingival surface and bring it up to the incisal edge, almost like you're painting a fingernail. So you want to apply a thin coat on the entire facial surface of the tooth. Okay. Now this product fortunately does not need to be cured. After this, it actually bonds better if you keep it a little wet, and the bracket will bond much easier. The next step is then to take the bracket holder, take a little of the bonding material, place it on the back of the bracket, and you can use your gloved finger and you kind of gently can tamp it into the back of the bracket so it gets into all the little nooks and crannies, if you will, to increase the bond strength. Then you go ahead and place it onto the buccal surface of the tooth, and there's a little dot on the bracket. You'll notice the dot is always towards the gingival aspect, and to be completely accurate, it's not only gingival, but it's to the distal. So in this case, this tooth is the upper left central incisor, number 9. So that's why that dot is up to gingival and distal. So place it into the center of the clinical crown, and you have to almost guesstimate, because this is a Type-it-on tooth, where the gingival height is. This is a CJ, so the gingival height, free gingival portion, will be above this, of course. So you want to guesstimate the center of the crown from the incisal edge to that free gingival margin. And again, you place it right in the center of the tooth. Once you place it in the position that you like, you actually push the tooth down, remove all the excess. That's very, very important, because that can create a few problems. One is plaque can accumulate around the bonding agent. Number 2, it can affect the placement of the wire, because sometimes excess composite will actually prevent the wire from going into the slot. And then third, it can actually affect the position of the bracket, because excess composite can allow the bracket to be away from the tooth on one side and prevent complete rotational correction. So anyway, so you want to remove all the adhesive, and when you place the bracket, you want to look at it mesial distal. You want to be centered mesial distally, and you also want to be centered incisal gingivally, and also you want to look at the tooth from above, like look down on the tooth, and you want to make sure that's along the long axis of the tooth. So if you look down, it should be right in the center of the tooth. Once you have that final position, you can actually press the tooth against the bracket to get the final seating to make sure it's absolutely accurate. Now once you're happy with the position, then you're going to light cure it. The nice part about it, this bonding agent, is that it's light cured. So that gives you really unlimited working time. And when you're happy with the position of the bracket, then go ahead and place your curing light. Now when you cure a tooth, you always want to place the light either at the gingival or incisal portion of the bracket. And remember that bracket, of course, is opaque, so light is not going to travel through the bracket. So you want to come from the side, again, above or below. And as you know, you cannot over-cure the adhesive. So the more you cure it, the better. In real life, we really like to cure it at least for 4 rounds of 3 seconds, just to make sure it's absolutely bonded to the tooth. Because one of the easiest things to prevent, ways to prevent bracket failure, is to really make sure the tooth is completely cured to the tooth. Okay, so now that we've cured it very well, then we're going to actually place the tie, it's called elastomeric tie, onto the bracket. Now you'll notice the elastomeric tie has a slight curve to it, and that's to facilitate placement. So what you do is you place the tape it on tooth onto the wire just a little bit away from that midline. You'll notice there's like a little midline mark on the wire. Hold the tooth onto the wire and then go ahead and place the elastomeric tie. Now when you place the tie, doesn't matter if you start from the gingival or the incisal portion, but you want to just gently walk the elastomeric tie around the bracket and then securely in place. Now what you'll notice is if you place the bracket ideally, the tooth should have a natural distal angulation, and you'll also notice that the bracket also leans back in the wire. In other words, it doesn't, it's not placed vertically, but it's actually angled back distally. And the other thing is the tooth has a natural curve when it's placed on the arch wire. So in other words, that 3 dimensions of the rotational correction, the angulation, and then the torque, or the front to back angulation, those all 3 dimensions are incorporated into the bracket design. That's called a prescription. So when people talk about orthodontic prescriptions, oh, I use XYZ prescription, they're talking about how the bracket is designed in terms of how they want the teeth to be angulated towards the finish. So that's the concept of prescription. Anyway, and again, if you placed it ideally, when you place the wire onto the counter, the wire should actually be fairly symmetrical in terms of the angulation, in terms of how far the wire is away from the surface. And again, okay. I'd like to review now with you emergencies. Emergencies are something that you'll see in the office, and it's something that I want you to feel comfortable taking care of, at least from a patient comfort point of view. The most common emergency you'll see is a broken bracket. Now that you've placed a bracket on the type-it-on tooth, you can see that the bracket is normally very securely bonded to the tooth. However, what can break the bracket or separate the bracket from the tooth is mostly diet related. We have kids that we review with them what they should not eat. The most common offender is chewing ice, popcorn, hard and sticky foods and candies, saltwater taffies. Any real hard object can actually separate the bracket from the tooth. The nice part about the modern bonding agents is that they're completely safe to the enamel. If the bracket does dislodge from the tooth, the enamel will never become compromised, because the weakest area or weakest link between the bracket and the tooth is the adhesive. So that is makes the orthodontic process very safe. So anyway, so if a patient presents to you with a loose bracket, the most common thing you'll notice is the bracket is either in front of or behind the center of the tooth. Another thing that can happen is the actual bracket can actually rotate almost 180 degrees, and then that serrated or etched portion of the tooth can then be actually into the patient's cheek, and this can actually be uncomfortable for the patient. So what you can do to remove the source of the problem is to actually remove the bracket. Now that you place the bracket, to remove a tie, you basically just use an explorer, and then you can go ahead and get into the actual bracket, remove that little tie, and then the bracket will actually come out or away from the tooth. And then it would be wonderful if you can give it to the patient, and then they can go back to the orthodontist to have that bracket rebonded. So that's the most common emergency you'll see. The other thing is a long wire. Orthodontic wires, especially in the beginning, are very light. And because they're light, they can actually rotate or travel within the arch. So in this case, you'll see the wire is long on one side. What has happened is the wire is actually shifted completely to the left. So how do we resolve that? You can actually use a hemostat in your office. We use what's called a wine guard, but basically you grab the wire at almost any point between the arch and actually grab the wire and slide it to the opposite side, and you'll see instantly now the wire is not long on that side and should be very comfortable for the patient. Now, to prevent this emergency from the get-go, what we do is called arch wire cinching. So whenever we place a light wire, we actually can bend the wire back behind the tube. So if you look closely, I'm going to grab the wire at the very end, and I'm actually going to make a little kink or twist. We call that cinching. And then can you see how the wire is now bent behind the tooth? And that will prevent that emergency from reoccurring. So that's something that we do on our side, but to prevent that emergency. Now the other thing you'll notice that when the patient's in a heavier wire, because the wire is filling up the bracket slot, it's very unusual to see any emergencies in terms of wire pokes, because the wire is going to have so much friction within the slot that's almost impossible for it to slide out from the back. And the last thing I want to cover, which is maybe difficult in the time constraints we have today, is the different bracket systems. Like the brackets I'm showing you here are actually ligatureless, meaning not only is the wire secured with a little elastomeric tie, but it's also secured by a little door closing mechanism. So in other words, it's using metal against metal. So it's a little door closing mechanism. But you can see that actually makes a little more, may make it more difficult for you to remove the bracket from the wire, but that's something we can review after the presentation today. Okay, thank you very much.